The following podcast is part of a certified educational activity titled Leveraging the Standard of Care in Hemophilia A, Evidence-Based Insights and Strategies for Developing Effective Personalized Treatment Plans. Access the entire activity and complete the post-test at peerview.com/MFK860. Downloadable slides and practice aids are also available.
Hi, this is Dr. Maisa Jambain from Tulane University in New Orleans. Welcome to this micro-learning activity, Leveling the Standard of Care in Hemophilia A. The goals of this program will be to increase your awareness of some unmet needs and barriers to optimal and equitable Hemophilia A care, enhance your understanding of the evidence and clinical benefits of current and evolving treatment strategies for the management of patients with Hemophilia A, sharpen your skills for developing individualized treatment plans using modern therapeutics, and augment your ability to address disease management challenges and enhance clinical outcomes for all patients with Hemophilia A. We'll achieve these goals through a series of concise educational modules that will explore recent developments with factor and non-factor therapies in Hemophilia A. This micro-learning activity offers you the opportunity to learn based on your own preferences and interests. Let's get started. You've just answered a question about unmet needs in Hemophilia A care. Let's look at some supporting evidence. As you can see, the current armamentarium in Hemophilia A can be grouped pretty much in three different groups. The first group is that of factor replacement therapy, and here we can find standard half-life factor VIII therapies, extended half-life factor VIII therapies, as well as the most recent ultra-high sustained levels of factor VIII replacement therapy. The second group include non-replacement therapies, which actually is divided into factor VIII mimetics as well as rebalancing agents. There is one factor VIII mimetic that has been approved for almost a decade now, less than a decade, and two rebalancing agents, which by definition are inhibitors of naturally occurring anticoagulants. These two actually rebalancing agents are anti-FVIIIs, and they have been approved in 2024. The third group is that of gene therapy, and there is only one product that has been approved in 2023 for Hemophilia A. Since its initial discovery, the goal of hemophilia therapy has been transformed from the prevention of premature death to normalization of hemostasis and health equity, now allowing patients to live similar lives to those without a bleeding disorder. But despite this progress, challenges remain, and joint development is the main or the most feared complication that actually we are still concerned about in the treatment of severe Hemophilia A. As you can see here in this joint outcome study, which aimed to evaluate the natural history of joint development and impact of primary or secondary prophylaxis on the prevention, limitation, or reversal of hemophilic arthropathy. And especially in the joint outcome study continuation, we can see that children who delayed factor VIII prophylaxis beyond 6 years of age had significantly increased risk of MRI, osteochondral damage, and higher annualized bleeding rate, as well as joint annualized bleeding rate than those who started prophylaxis prior to the age of 2.5, as you can see in the first two graphs. But also, despite early prophylaxis, this data shows evidence of joint disease in patients thought to be very well controlled, as you can see in the second graph, especially in the blue columns, where even with early prophylaxis in those patients that had very well controlled prophylaxis, there was still evidence of joint disease as detected on MRIs. In addition, on this slide, you can see a publication that was actually published in 2023 and looked at the outcome measures and how these outcome measures should evolve and adapt according to changing scenarios now with less frequent bleeding events and longer life expectancy of patients. now with novel comorbidities. They also recommended that these outcome measures should evolve and adapt according to new opportunities, like technological advances that are introducing new ways to collect and analyze data. So per the expert opinions in this manuscript, you can see that they actually covered the annualized bleeding rate and annualized joint bleeding rate, acknowledging that this remains central to evaluating efficacy and safety of treatments. But now with clinical benefits improving with modern treatments, this endpoint may no longer be considered sensitive enough. In addition to that, health-related quality of life and PROMs become increasingly important. However, the most frequently or the available tools now are often time-consuming, limiting their use in practice. They also highlighted the importance of lab assessment or biomarkers, especially that factor activity now is not anymore sufficient with the advent of non-replacement gene therapy, and stressing on the importance of standardizing assays that will capture the hemostatic activity of these non-replacement therapy. They also covered the safety assessment, highlighting that safety outcomes as a whole are very heterogeneous and require development of appropriate monitoring protocols with the various treatments. So in summary, the outcome measures should be tailored to the various therapies and patient needs, considering differences in age, comorbidities, and response to treatments. In addition to that, you can see here actually in this study that looked at patients from the United States that were recruited by Picnic Health. Those patients were with moderate or severe hemophilia A, so levels equal or less than 5%. The patients were asked also to complete bleed treatment and quality of life, and they were stratified based on their prophylaxis product class. The results of this Picnic Health based study showed that 61.4% of patients on standard half-life, 70% of patients on extended half-life, and 62% of patients on emicizumab, respectively, had more than at least one bleed event within the first year, and that most of their quality of life affected areas were physical functioning, ability to participate in social roles and activities. They also found that patients reporting a recent bleed had worse scores. Of course, I mean, the data from this study have a lot of limitations because it's a Picnic Health, so like it's through a third party. Patients were not directly approached by their providers, so there is probably a selection bias in the study. But in summary, it does highlight that there is the bleed at least once a year persists, and that has an impact on the quality of life of the patients. In this other study that was published in 2024, data were actually collected from Adelphi hemophilia disease specific program, and they were from 47 physicians on 244 patients with moderate or severe hemophilia A. Also, the patient and physician reported outcomes and bleeds were evaluated. Here also, you can see that the patients were stratified based on prophylaxis product class. And of these patients, 41% on the standard half-life, 52% on the extended half-life, and near 38% on the non-replacement therapy experienced at least one bleed per year. 25% reported joint problems, and 28.1% of patients were unable to work full-time. That's because of their hemophilia A. Of patients with available patient-related outcome data, 84% reported regularly avoiding physical activities due to hemophilia A, and 80% reported worrying about having breakthrough bleeds. So despite the progress in hemophilia treatment, hemophilia is still affecting the quality of life of patients, and bleed persist. In addition to that, we can see that there is still inequity in taking care of patients, especially in females with hemophilia A. As you can see here, and the discrepancy between the numbers of women with hemophilia A and men with hemophilia A seeking care at hemophilia treatment center, and especially as reported in the population profile and community counts, with women only accounting between 6 and 13%. And if we think that for every male patient with hemophilia A, it's estimated that there are like 1.5 female carriers between siblings and daughters, approximately 1/3 of these hemophilia carriers or female carriers will have low factor levels, this suggests that there is underdiagnosis of affected females. These disparities also affect the care of patients with mild to moderate hemophilia. You can see the impact of these disparities on the quality of life and the functioning of males and females with mild and moderate hemophilia, with their inadequate disease management leading to absenteeism from work as well as school, leading to pain and limited mobility and therefore impaired daily functioning, less engagement also with physical activities. And therefore, we need to probably, the HTC and the hemophilia community also need to engage them more to probably seek better care with their provider team. And especially probably more related to women, we can see that the healthcare provider dismissal of the symptoms or the inability to quantify really the bleeding symptoms in women and differentiate what is pathologic from physiologic is still a barrier in optimizing care of women with hemophilia. In this Dynamo study that assessed joint outcomes in males with non-severe hemophilia A between 24 and 55 years, you can see actually that despite a low frequency of joint bleeds, there was actually a substantial proportion of this population presented with joint changes on MRI, especially in the ankles. As you can see, there were actually soft tissue changes in the elbows, knees and ankles, and the osteochondral changes in the elbows, knees and ankles were also reported as 0, 20%, and 35% of patients respectively. So this population also suffers from the impact of joint bleed, even if it was not reported before, as seen on the MRI results. In this other study that was published by Wang in 2020, you can see that there is a linear loss in proportion of normal range of motion with age. And that is, you can see the different actually curves based on the factor activity level, with the lower curve more consistent with severe disease. And you can see that the loss is definitely more significant there with age. But the three curves in red, in green, and in orange, with levels between 1% and 9%, you can still see a linear loss that is more significant compared to normal patients or normal persons with normal factor VIII activity. So in summary, persons with mild and moderate hemophilia A lose joint range of motion over time compared with unaffected population. Is there still a role for standard half-life factor VIII products in the evolving hemophilia treatment landscape? Let's discuss that. What are the standard half-life factor VIII products in hemophilia A? You can see here that there are different products, octocog alpha, lonoctocog alpha, simoctocog alpha, turoctocog alpha, and moroctocog alpha. They're all approved, and they have actually a significant safety advantage over plasma-derived factor VIII. However, their half-life is relatively short, varying between 8 and 12 hours, so requiring frequent infusions, around 3 to 4 times per week. While the evidence supporting the role of standard half-life product in prophylaxis has been actually shown in the joint outcome study that we discussed earlier, We're going to discuss actually here more of a comparative analysis most of the comparative analysis that were done between standard half-life and some extended half-life factor VIII products in terms of having comparable bleed control. 333 of these patients, or 66%, were on prophylactic recombinant factor VIII therapy, as you can see here. The total dose per week was very similar between the standard half-life and the extended half-life products. And this actually study looked at analyzing the annualized bleeding rate and treatment adherence among patients with hemophilia A receiving the standard half-life and extended half-life products from the Adelphi disease-specific program. You can see that the patient adherence to replacement factor therapy is complicated, again, as highlighted here, and can depend on a number of factors. The clinical implications of a single missed dose with once-weekly extended half-life product regimen versus a standard half-life regimen with multiple infusions per week should be considered. So you can see that there was also, however, the annualized bleeding rate were comparable, as you can see, between pretty much the standard half-life products and the extended half-life products, as shown here in the two columns, clear blue and dark blue. Other real-world data and evidence highlighted on the effectiveness and safety of standard half-life factor VIII, like this AHEAD international study that evaluated the long-term safety and efficacy of standard half-life factor VIII in patients with moderate or severe hemophilia A. And that included 905 patients receiving treatment with octocog alpha. They were analyzed actually in 110 study clinics across 22 countries worldwide. There were 2 women in this study, and the age ranged between 1 month and 78 years old. The primary objective of this study was assessing the joint health outcomes in participants receiving octocog alpha in routine clinical practice setting using any therapeutic regimen, and it was measured using Gilbert scores. The median Gilbert scores range from 0 to 0.3 in children aged 2 to under 12 years of age with severe disease, and from 0.2 to 0.6 in those with moderate disease, highlighting suggesting that standard half-life factor VIII prophylaxis can preserve joint health. Also, the median Gilbert scores ranged from 0 to 1 in patients in adolescents aged 12 to under 18 with severe disease, and from 0 to 3 in those with moderate disease, although the patient numbers were low here, suggesting again that standard half-life factor VIII replacement can preserve joint health in this population. Standard half-life factor VIII still play a role in hemophilia care in the U.S., as you can see here, while probably their use in prophylaxis has really lessened with the availability of more convenient extended half-life products or even non-factor VIII replacement therapy. We're still using them in the perioperative management to treat on-demand bleeds, as well as in the hospital setting. The various hospitals actually refuse to carry any of the extended half-life products on their shelves due probably to the higher cost. We still use a lot of these also standard half-life therapy for immune tolerance induction, as well as in conjunction with emicizumab or even some extended half-life and ultra extended half-life factor VIII prophy. And there are also some patient factors that we should consider, like patient preferences. Some patients, if they're satisfied with the standard half-life factor VIII prophy that they're on, a lot of them refuse probably to change. Some older patients, and those are usually the older patients that have acquired more experience with their standard half-life products. We see also more of the mild patients being prescribed the standard half-life product for on-demand. And it could be also that the choice of the product is restricted because of allergies to hamster proteins, as most of the extended half-life and even the mimetic use hamster protein. As the treatment landscape continues to expand, it's important to understand the similarities and differences between available treatment options to ensure we are choosing the best regimen for our patients. Let's explore in this module the evidence with our extended half-life, factor VIII, and non-factor strategies. On this slide, you can see the extended half-life factor VIII products that are approved for treatment of hemophilia A. We have actually 4 extended half-life products and 1 ultra extended half-life product, efanesoctocog alpha, while the other extended half-life products have been in the market for a little bit longer. And you can see that the modification to extend their half-life was either by Fc fusion or random pegylation or site-specific pegylation or site-specific glycopegylation. And while the half-life of these products was slightly increased from less than 12 hours to, you can see here, between 14 and 21 hours, it wasn't until the use of specific techniques in the ultra extended half-life factor VIII efanesoctocog alpha that there was a significant success in extending half-life of factor VIII replacement therapy. As you can see here, the half-life increased to 42 to 52 hours. As far as pediatric and adult dosing, you can see here the efanesoctocog alpha has one dose across ages, which is 50 units per kilogram once weekly, while for the other products, some of them are not approved for less than 12 years of age, as the domactocog alpha, and some are approved with 50 units per kilogram twice weekly, while the adult dosing varies between 50 units per kilogram every 4 days or twice weekly or every 5 days per molecule. In addition to that, there is the other group, which is the non-factor VIII replacement therapy, with most of the data and experience really available with the factor VIII mimetic, or emicizumab, which is the only really factor VIII mimetic approved now for hemophilia A with and without inhibitors in the U.S. Like factor VIII, it does enhance actually the factor X activity generation by facilitating interactions between activated factor IX and factor X. This actually, factor VIII mimetic, achieve a steady state hemostatic effect that does not really correlate to factor VIII levels. So unlike the other factor VIII replacement therapy, where there is a peak and then the factor levels decrease depending on the clearance rate back to the baseline, with non-factor therapy, it is a steady state of what we call by hemostatic equivalence, pretty much when compared to these factor replacement therapy. There were several clinical trials that actually addressed the outcomes with factor VIII replacement therapy and factor VIII mimetic therapies. You can see that the clinical outcomes were pretty much similar in terms that prophylaxis did lead to improved joint health, ABR, and quality of life with the standard and extended half-life product, as well as with the efanesoctocog alpha and the factor VIII mimetic. With the factor VIII replacement therapy with standard half-life or extended half-life, higher trough levels demonstrated hemostatic efficacy, resulting in less frequent infusions with extended half-life compared to standard half-life, leading to reduction of treatment burden and better bleed prevention. But breakthrough bleeding can still occur, and development of factor inhibitors can still also occur. When we move to efanesoctocog alpha, we can see that the significant improvement in half-life compared to standard half-life and extended half-life product with 3 to 4-fold higher half-life definitely translated into less frequent dosing and a more convenient schedule with once weekly. However, here also you can see that the breakthrough bleeding can still occur and development of factor inhibitors can still occur. Now, with the factor VIII mimetic, the subcutaneous administration, as well as the infrequent dosage once weekly or once every 2 weeks or once every 4 weeks, added much to the convenience of this product administration. In addition to that, the subcutaneous administration, especially from birth, reduced the risk of intracranial hemorrhage and joint bleeds without adding much burden on getting a port, or especially in this population where IV access might be a challenge. However, breakthrough bleeding here also can still occur. And there were cases of thrombotic microangiopathy and neutralizing anti-drug antibodies that have been reported, some of which might affect the efficacy of this drug. If we look at the real-world trials or data on switching from extended half-life to factor VIII therapy to emicizumab, there is actually this one that analyzed the total mean weekly consumption, dosing frequency, product wastage, and annualized bleeding rate among patients with moderate to severe hemophilia A without inhibitors, so factor levels less than 5%, after switching to emicizumab or extended half-life product. And this study was conducted using data from the Trio Health specialty pharmacy partners. The baseline period, which included at least 6 months before the index date, which was the switch to emicizumab, patients' data was collected while they were on their factor VIII prophylaxis. And then after that, after switching to the emicizumab, it was an observation period where also data was collected and it was compared to the baseline period. The results of this study showed that post-switch mean weekly prophylactic consumption was around 6,000 IU per kilogram for the rhodioxocog alpha PEGL, and 109 milligram for emicizumab. Emicizumab showed significantly higher mean product wastage, however, compared to the extended half-life product. And the post-index annualized bleeding rate decreased in both cohorts. However, there were no differences between cohorts for all bleeds for each blood type, suggesting similar treatment effectiveness in the factor VIII prophylaxis and emicizumab. In this other study, which is really an indirect comparison of efanesoctocog alpha versus emicizumab, so it wasn't head-to-head like the other study. It was just actually the results the results here were actually of adjusted comparisons between the once weekly EFA with the Extend 1 arm A and emicizumab once weekly with the prior prophy from Haven 3. So they took actually data from Haven 3 and data from Extend 1 and compared the efficacy of these two drugs. So it wasn't definitely direct head-to-head comparison. With the limitation, of course, of this data, we can just show that there was an efficacy benefit of EFA that was shown over emicizumab with significantly reduced rates of any bleed, any treated bleeds, and any treated joint bleeds. Again, keeping in mind that the patient population was different. It's not head-to-head. It's taking results from two different studies and comparing to each other. There is ongoing innovation with non-factor therapies in addition to optimizing or second generation, if you want to say now, factor VIII mimetics that include pretty good list, starting with MIM8 that is now at phase 3, but there's also the NXT007, which is at phase 1-2, and INNO8 at phase 1. And a lot of these factor VIII mimetics were actually pretty much modified in terms of their affinity to factor 9, affinity to factor 10, their potency, again, how much we can define potency with the factor VIII mimetics. But they're definitely optimized somehow factor VIII mimetics compared to the currently available emicizumab. There are also the rebalancing agents with the two currently FDA-approved anti-FVIII, concizumab, that is given daily, and marstacimab, which has been approved in the U.S. and Europe. There are also other rebalancing agents with actually using the technology of small interference RNA, lowering the antithrombin 3 with fitusiran. And this is currently at phase 3. And then there was an anti-APC or SERPIN-PC. However, this product has been discontinued, and it wasn't because of concerns about safety or it wasn't well tolerated. It was just the company determined that the investment in this product, especially after the approval of marstacimab, is probably not worth it. Now, moving to Module 4, where we're going to talk about individualization of therapy as a key for improving outcomes in patients with hemophilia. So we all agree that the standards for prophylaxis have evolved, that now with better factor VIII products, factor VIII replacement therapies with better half-life and more convenient administration, we can easily target higher factor VIII trough levels. But why do we need to really target higher trough levels? So we're going to talk first about the PROPEL study that looked at targeting higher factor VIII levels with rurioctocog alpha pegol, and that did effectively reduce bleeds. And only actually when factor VIII levels were equal to and above 20%, there was a significant lower total spontaneous joint and injury-related anomalized bleeding rate, as you can see here on the graph. In addition to that, the Extend-1 study did show actually looking at the PK of F1-isotocog alpha and how it compares to the standard half-life products and extended half-life products here, which were octocog alpha and rurioctocog alpha pegol. It did show that once one dose actually provided coverage or provided actually higher factor VIII levels, sustained levels for longer period of time, with 4 days out of the week levels in near normal to normal, and even at day 7, the troughs were much higher, around actually 10%. So you can see also in this Extend-1 that switching from pre-study factor VIII prophylaxis, which would have been a standard half-life or even extended half-life, did result in decreased ABR from almost 3 to less than 1 or 0.7. So it was like 77% reduction. This again highlighting that higher sustained levels for longer period of time are more protective and desired in terms of preventing joint bleeds. So when we talk about how does this translate into in individualizing factor prophylaxis, and especially taking into account also the patient's lifestyle and activities. You can see also in this study that was published by Malango in 2014 that individualized factor prophylaxis did lead to improved outcomes. So there's no one factor, or there's no one prophy regimen that should apply to every patient. And whether it's weekly or more frequent, the importance is to individualize prophylaxis and tailor it to the patient needs. As you can see here, that even if the median dosing interval was around 3.52, patients without bleeds were near half of these patients, or 45%. The adherence to treatment also plays an important, very important factor in improving outcomes. So not only individualizing therapy to the patient needs, but also assuring that the patient is adherent to their treatment, as you can see here, and that might be improved with probably more convenient therapy. But again, just adherence to the therapy itself is a major factor in improving the outcomes, whether it was every 4-day regimen or every 7-day regimen. In this small study that included 13 patients of direct comparison actually with 6 months of PK-guided low-dose extended half-life factor VIII prophylaxis with moderate intensity physical activity for 6 months, you can see that there has been improvements in rate of bleeds, quality of life, and musculoskeletal status. And again, highlighting that tailoring the prophylaxis, sometimes guided by PK with the patient needs and also their physical activity, does lead to improved outcomes in terms of annualized bleeding rate and annualized joint bleeding rates. This is another publication that looked also at PK-guided factor prophylaxis and how it improves bleed protection. You can see also that in this manuscript, there was the overall PK-guided factor prophylaxis significantly reduced the annualized bleeding rate and spontaneous bleeding compared to just classical weight-based dosing regimen. However, there were no significant differences in traumatic bleeding were observed. There are different tools that actually can help providers really like individualize factor VIII prophylaxis. On this slide, there are probably the most frequently used tools, as you can see here. The WAPS Hemo used population-based PK data, as well as MyPK-Fit. Really like these two tools help in a PK-guided dosing for prophylaxis. And based on the CHEST-2 real-world study, this has beneficial impact on clinical and healthcare resource utilization outcomes in patients with hemophilia A. You've just answered the question about how to manage a patient with inhibitors, which is an ongoing challenge in taking care of patients with hemophilia. Let's just review some supporting evidence, recommendations, and strategies for addressing this challenge, as well as other common management challenges in hemophilia care. So as I said, the main challenge in taking care of patients with hemophilia remains really the development of anti-factor VIII antibodies or inhibitors. As you can see, those are actually allo-antibodies by definition to exogenous factor VIII exposure that neutralize the function of the infused cloning factor concentrate, making the treatment with factor VIII replacement therapy not anymore an option. It can be detected and quantified using Nimegen-modified Bethesda assay. The incidence has been reported around 30% in patients with hemophilia A, but of course, like more frequently, it's encountered in patients with severe hemophilia, but patients with moderate or mild hemophilia are still at risk of developing inhibitors. So we should always monitor for the development of inhibitors in this patient population, especially that now they're being more and more exposed to continuous factor VIII prophylaxis. It is associated, again, with higher disease burden, including increased risk of musculoskeletal complications, bleeds, pain, physical limitations, and treatment challenges, especially, I want to say, probably the management of on-demand bleeds, as well as the perioperative management. And that does impact patients' physical functioning capacity for physical activities and quality of life. Here are some recommendations for testing and managing patients with factor VIII inhibitors. We do recommend testing after initial exposure to a factor. We do recommend testing for inhibitor after intensive factor exposure. So, for example, if they had to dose like daily for more than 5 days. We do also recommend testing if there is recurrent bleeds or target joint bleeds despite adequate clotting factor concentrate. So like as investigation of the failure of their clotting factor VIII concentrate replacement therapy, why they're not also responding as expected to the clotting factor concentrate. So if there's no like good recovery of their factor levels after exposure to a certain dose of factor, or there was change in their half-life. If there is also around before surgeries or also after surgeries, if there was intense therapy. In general, if there is suboptimal response, whether it's post-op or in the treatment of bleeds, or suboptimal results of their prophy, it's recommended to check for inhibitor development. How do we manage the factor VIII inhibitors? The standard of care remains immune tolerance induction to get rid of the inhibitor. The ITI success rate, however, are not 100% based on our experience. They can get as close as like 70% in patients with a severe hemophilia A. While there is actually, there were several studies that looked at predictors of success of ITI, or like what would be the optimal regimen in terms of like what product we should use, plasma-derived versus recombinant, the dose of the factor, the duration for ITI. We're still, except for the plasma-derived versus recombinant, which was probably, supported more by the ACCPE trial. The exact dosing, the duration to assess if there's successful ITI or no is still not very clear. Some studies suggest that rapid achievement of negative inhibitor titers can be achieved using extended half-life products. However, patients who fail ITI, it's still like a very gray zone here and undefined. How do we classify them? How do we define exactly ITI failure? And what do we do as next step? And when do we stop further attempts of ITI and just label them with ITI failure and move to other therapies to prevent bleeds in them? So when we look at like why it's important to tolerate, or is it really important to tolerate or not tolerate, and the benefits and considerations for ITI, Kempton in a publication a recent publication in 2024 looked at the data from Community Counts actually registry on the effect of ITI, and it did found that the receipt of ITI was associated with almost like 30% lower bleeding rates than patients that did not receive ITI. There were also significantly fewer ED visits in these patients compared to those that had not had successful ITI or did not even receive ITI. As far as quality of life, it was better among patients with successful ITI with lower chronic pain, less limited function. And patients with successful ITI was associated with fewer joint procedures and missed days of school work, improved education attainment relative to partially successful or failed ITI. So quality of life, cost, like fewer ED visits, and bleeding rates, again, based on this Community Counts registry, were better in patients that have achieved successful ITI compared to those that have failed ITI or did not receive ITI. However, there are some considerations that we need to take into account when we talk about ITI with the patients and the families. It does carry a high financial and emotional burden during the ITI itself, and does require very high adherence from the patient and the caregivers. But probably if we parallel or if we face this with the higher cost of ED visits and hospitalization and the impact on quality of life, that can offset the added cost of ITI. we'll have to again determine the optimal timing where we can determine that further attempts or continued attempts to reach successful ITI is not required. And therefore, we can stop ITI if we haven't achieved good results. In addition to the development of inhibitors and how do we deal with inhibitors in patients with hemophilia, there is still an ongoing challenge with gender inequity in hemophilia care. So despite the efforts to raise awareness, many hemophilia carriers and female persons with hemophilia remain undiagnosed. We did as you can see here, if we look at like how male patients with hemophilia compare to female patients with hemophilia, they're in males, like most of them, they have the baseline factor levels routinely measured. While in women, we can see that the baseline factor levels are not systematically measured. A lot of these patients usually do not seek any medical attention or any advice till they're pregnant or they want to undergo a surgery, and they're referred by their doctors to the hematologist to check their baseline and come up with a procedure plan. That's the best scenario that can happen. Some of them will probably undergo the surgery or the pregnancy and without any guidance, and therefore put themselves at high risk of bleeding and complications. There's also ambiguity or not enough it's not very clear in terms of how do we classify asymptomatic versus symptomatic carriers? What is the best factor assay to determine the baseline factor levels? Which one correlates better with their phenotype? You can see also that, that might lead to diagnostic delay or not even being diagnosed at all. So definitely, while men have access to multidisciplinary and specialized centers, we can see that women receive much less attention and have less access to specialized care. Beside the development of inhibitors and the gender inequity in the treatment of hemophilia, adherence is a main problem that we still have to actually address. Because as I mentioned before, the adherence to treatment is coupled with better outcomes. And really, until we identify the barriers to adherence, we will not be able to address them. While probably the transition to adulthood is a main one, there's also treatment fatigue that we have seen in a lot of these patients. Difficult venous access, as I said, a lot of the patients usually mention that my veins are getting tired, developing these nodes. I have only one vein. I'm trying to alternate. However, with the limitation and my range of motion, my elbow range of motion, I'm stuck with only this vein, and I feel like it's getting fatigued. So the venous access is definitely a major challenge that these patients encounter. And then probably there's also the lack of awareness about long-term joint damage or what a minimal joint complaint might lead on the long term. So re-educating patients about even if you're not having the frank overt bleeding, sometimes these oozing or microbleeds, again, we have to actually redefine what microbleeds mean, but these oozings might lead to or will eventually lead to long-term joint damage. And then sometimes it's hard for a prescriber to perceive the impact of the treatment on social participation, but if we do not engage the patients, we will not really understand how much of a barrier that is. Whether it's interference with the schedule or also trying to not distinguish themselves from their peers and therefore sometimes hiding their treatment and everything that is associated with that treatment or their disease and everything that is associated with this disease from their social circle. And finally, the poor self-management skills, which is clear contribution to non-adherence and therefore bad treatment outcomes. At the end, final take-homes that we can go with about caring for patients with hemophilia. Again, a reminder that good clinical care is a two-way street, and we need to work closely as a provider with the patient and vice versa, because living with hemophilia has dramatically evolved but still carries its challenges. The shared decision model and tailored therapies to patients' phenotype, needs, and lifestyle is the first step in determining success of therapy. Development of inhibitors and joint bleeding with subsequent hemophilic erythropathy remain the main feared complications of hemophilia. Efforts should continue to expand comprehensive care to women with hemophilia as well as patients with mild and moderate hemophilia. And research addressing aging in hemophilia is encouraged as providers need now more guidance on how to manage these patients' comorbidities.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Takeda Pharmaceuticals U.S.A. Incorporated. To access all materials for this activity, visit peerview.com/MFK860.